Hi, I'm Dr. Jason Siegel, and this is Neuro Now. One of the most common questions I get is, what is teleneurology? It's a very good question with multiple definitions, but essentially, teleneurology is a form of telemedicine that diagnoses and treats neurological diseases through technology such as computers, tablets, and smartphones. The idea of actually not being in a room with a doctor is very foreign to most people and in some ways scary. What if the doctor misses something? How is he going to perform a full neurological exam if I can't be in the room with them? I think these are very good questions, and in this video, I hope to address some of the ways teleneurology can be very successful in diagnosing and treating some of the most common and disabling neurological diseases. Teleneurology can provide the same high level of care as in person visits, and in some cases, has been shown to have better outcomes and higher satisfaction among both patients and caregivers. As I discussed in previous videos, sports-related concussions are a very common and major problem in the United States. Athletes need to be evaluated both at the time of injury and oftentimes days and months afterwards. Unfortunately, there is a lack of neurology support, especially in small schools and in very rural or urban areas. In 2017, researchers compared teleneurology versus sideline concussion assessment in college football players using three types of concussion assessment tools: the standard assessment of concussion, King-Devick test, and balanced error scoring system. They found 100% agreement in the scores obtained between the teleneurologist and the sideline team, and 100% agreement on whether the player should have been taken off the field or able to return to play. I like taking care of patients with post-concussion syndrome because they are very complicated and very complex. Teleneurology is so efficient it allows me to address their many concerns. Several studies have shown that months after injury, counseling and education over telemedicine has helped symptom burden and the impact of symptoms on daily functioning and overall quality of life, even better than in-person visits. Dementia is one of the most disabling neurological diseases, and these patients are often unable to drive to appointments or even organize their own transportation. This puts extra responsibility and burden on friends, family, and caregivers. Studies have shown that teleneurology helps reduce appointment cancellations, improves transition of care, and has high levels of patient and family satisfaction. In fact, one study in 2020 during the heart of the pandemic showed that teleneurology slowed the progression of decline and reversed the falling trend in quality of life. It also improved the physical and mental health, perceived burden, and self efficacy of caregivers. When I see patients with cognitive issues, I can easily perform standard bedside cognitive assessments, such as the Mini Mental State Exam and the Montreal Cognitive Assessment. These assessments test multiple domains, including executive function, language, memory, and abstraction. The diagnostic accuracy of telemedicine has been studied for over 25 years, and the diagnostic accuracy is somewhere between 76 and 100% compared to in person visits. There also appears to be a potential treatment benefit of using teleneurology. One study found that patients who used teleneurology were treated for a longer period of time than patients treated primarily with in person visits. This suggests that teleneurology can lead to faster diagnosis and faster initiation of treatment plans. Epilepsy is one of my favorite things to treat with teleneurology because we can really get creative with the types of technology we use to help people. For example, patients with epilepsy can have their seizures or seizure-like events recorded on their smartphone and then send those videos into the neurologist to be analyzed. In fact, one study found that the odds of receiving a correct epilepsy diagnosis were over 5 times greater if a smartphone video was incorporated with the history and exam compared to just the history and exam alone. Another great use of teleneurology in epilepsy patients is the idea of the ambulatory EEG. The gold standard is a prolonged video EEG, and oftentimes this requires the patient to be admitted to a hospital, hooked up to an EEG for several days until a seizure is found. This, as you can imagine, is extremely inconvenient for patients, especially if they are young and need to be working and can't drive and things like that. Ambulatory EEGs can happen in the comfort of the patient's home. A company will come and hook a patient up to an EEG. They'll be able to go about their daily business at home, still getting very high quality and accurate EEG findings. The EEG is then read remotely by a board certified epileptologist, and the report is given to the patient's neurologist. Patients with epilepsy, especially if they're newly diagnosed or newly symptomatic, often have driving restrictions, which prevents them from actually getting to a neurologist's office. Patients are far more likely to show up for teleneurology visits than they are for in person visits, and the satisfaction rates are consistently above 90%. Several studies have shown that between teleneurology visits and in person visits, there are no differences in breakthrough seizures, number of seizures, hospitalizations, emergency room visits, or medication compliance between teleneurology and in-person neurology. Headaches are one of the most common reasons people see neurologists, and they're one of the most common problems I see. A very important part of a headache workup is to identify any red flags. Red flags are indicators that maybe the headache is because of something more serious than garden variety tension headaches or migraines. These can include systemic symptoms, secondary risk factors, neurological symptoms or signs, the onset of the headache, the age of the patient, how the headaches are progressing, and if there's any pressure-related symptoms or signs. The headache interview can, and in some cases should, take a long time, so the efficiency of teleneurology allows me to get all the information I need from the patient in as much time as it takes without the patient feeling rushed or hurried. Patients with headaches, like migraines, often don't find the best treatment the first try. There's often back and forth, experimentation, and trial and error. This requires a very high level of communication between the patient and the physician. Teleneurology allows me to keep in great communication with my patient through things like the patient portal, or email, or calling, or even text messaging. This allows me to know if the patient is helped by the treatment or is having side effects and something needs to be changed. The patient really appreciates this because they don't have to wait days and days for a response or weeks and weeks to see a neurologist. Studies have shown that with headache patients, teleneurology saves time and cut costs. Other studies have shown that there is no drop-off in care and clinical outcomes using teleneurology, and that it does not add risk or affect safety of taking care of headache patients. There are many types of movement disorders, but essentially they all make it very difficult for patients to be mobile and get to doctor's appointments. Perhaps the most well-known movement disorder is Parkinson's disease. Some of the clinical assessment for Parkinson's disease does require the physician to be in the room and examining the patient. For example, cogwheel rigidity requires the physician to move the patient's arms and legs to see if there's any stiffness. So how am I able to diagnose and treat Parkinson's disease without actually laying hands on my patient? Well, I take advantage of the other cardinal findings of Parkinson's disease: soft speech, decreased blink rate, decreased facial movement, shuffling gait, falling, and resting tremor. Using teleneurology, I have the advantage of seeing a patient ambulate in their own house. I can see where the tripping hazards are. I can see if they hesitate in doorways, if they're unsteady during corners, if they're using gait aids like walkers and canes, and if they're using them appropriately, and how they might actually be subconsciously coping with their deteriorating gait by grabbing onto furniture and walls. In fact, virtual gait analysis has been shown to be as accurate as in-person analysis for patients with Parkinson's disease. And of course, teleneurology helps with caregiver burden. A national randomized controlled trial tested teleneurology versus in-person visits with people with Parkinson's disease. And what they found was that in-home visits with teleneurology were feasible with no worsening clinical outcomes, no increase in emergency room visits or hospitalizations, and an improvement in caregiver burden. In my opinion, peripheral and neuromuscular diseases are some of the most difficult to manage with teleneurology. Some of the very important aspects of the neurological exam, like sensation and reflexes, I just cannot replicate with teleneurology, or at least not very well. That being said, there are some peripheral diseases that can be managed with teleneurology. Myasthenia gravis, for example, is an autoimmune disease which prevents the nerves from communicating to the muscles. The key feature of myasthenia gravis is what we call fatigable weakness. That is, weakness that worsens the more and more muscles are used. So whether it be eyes, eyelids, facial muscles, speech, breathing, or the arms and legs, there's a series of tests I can do to bring out the fatigable weakness and help support the diagnosis of myasthenia gravis. One time I did a teleneurology consult in an emergency room with a man who had weakness, and they had suspected was having a stroke. I saw that he had fasciculations, muscle wasting, and stiffness spasticity. And in general, this mix of lower and upper motor neuron findings is indicative of amyotrophic lateral sclerosis, or ALS. And that's what the patient ended up having. The best ALS care is a multidisciplinary approach of neurologists, physical, occupational, and respiratory therapists, speech therapists, nutritionists, and many others. Many centers around the country have these available to patients, but they have to get there, which can be very difficult if they're bedbound or stuck in a wheelchair. But nowadays, academic centers, private practices, and private companies are bringing that multidisciplinary approach to the patient via teleneurology with very good results and high levels of satisfaction. Teleneurology has been around for decades, but really came into the public consciousness during the COVID-19 pandemic when doctors of every specialty needed ways to still see their patients despite quarantines and social distancing. Teleneurology is efficient, effective, and safe. It provides a high level of care consistent with in person visits and is ideal for patients with poor mobility and difficulty with transport. It allows for better scheduling flexibility for people with busy jobs, and it allows for better access to neurologists in places where there might not be, like very rural areas or even the very urban areas. My goal is to use the best technology to see patients quickly, make fast and accurate diagnoses, initiate treatment plans quickly, and have the ability to check progress with efficient and fast follow ups. I think teleneurology is here to stay. I think the more and more patients use it, they'll see the obvious benefits and ultimately choose it over in person visits. I believe in teleneurology so much, I gave up a great job in order to start my own teleneurology practice. I hope you enjoyed this video and I hope you found it interesting. If you did, please like, subscribe, and share it so other people might benefit from it. If you have questions or comments, put them in the comments section below or email us at office@yourneuronow.com. Feel free to reach out to us through any of our social media outlets, Twitter, Instagram, TikTok, Facebook. I have a list of references I use for this video in the description. Thank you so much for watching, and I'll see you next time.